Welcome and thank you for joining our webinar, Critical Care, Increasing the Capacity of Allied Health Training Programs. We're excited to share our research for our most recent report, Meeting California's Demand for Allied Health Workers. We're also thrilled to have our expert panelists of education and policy leaders to reflect on our findings and to learn more about what they're doing to advance these solutions and close the gap. Before we begin, some logistics. If you have any questions, please use Zoom's Q&A function. We will try to answer all of your questions. If we don't, we'll try to follow up with you afterwards. The slides and recording will be shared in a follow-up email to everyone. The webinar has three main components. First, you will hear from Gail Yen, California Competes' Senior Policy and Research Analyst, who will share research from our report. Then I'll facilitate a conversation with our panelists. We'll wrap up with a Q&A with your questions for our expert panelists. Before we jump into the research, let me share a bit about California Competes. We at California Competes aim to solve the state's thorny economic and social problems by conducting rigorous higher education and workforce policy research. We view higher education as both a vaccine and an antidote against economic stagnation and social stratification for individual Californians, our communities, and the state's economy. We believe long-term economic growth for California will be accomplished through shared prosperity. Okay, let's get to our research, which Gail will present.
Great. Thank you so much, Susan. Our research builds off of the analysis the consulting group McKinsey & Company did last year on current and projected demand for the 10 largest allied healthcare fields. And we examined the extent of the allied healthcare worker shortage. Based on our analysis and McKinsey's estimates, there will be up to 63,000 new jobs every year, but we are only going to be able to supply about 27,000. Therefore, we estimate that there would be a gap of about 36,000 unfilled jobs per year in the highest demand allied health professions. Now, when I say the highest demand allied health professions, I mean that our study focuses on the top 10 high demand allied health professions that came from McKinsey's analysis. The top 10 professions include health technologists and technicians, home health aides, licensed practical and licensed vocational nurses, massage therapists, medical assistants, medical and clinical laboratory technicians, medical coders, nursing assistants, pharmacy technicians, and physical therapists. There are many reasons why there's such a large gap between the supply and demand of allied health professions. One of the big contributors to the gap, and the one that we focus on, is the lack of access to and availability of clinical training hours. These hours are what's needed for students to complete in order to be licensed or certified. But the hours required have large ranges depending on the allied health professions, as shown in this table. So for example, nursing assistant students need to complete 100 clinical hours in order to be licensed. We then wanted to see how many additional clinical hours are needed to fill the new unfilled jobs. So for the roughly 13,000 annual unfilled nursing assistant jobs, that means there would be 1.3 million additional clinical hours needed. We did the same analysis for the other 9 allied health professions and got a total of up to 6.5 million additional clinical hours needed each year to close the gap. So how do we solve this issue? After reviewing literature and conducting interviews with key experts in the field, we broke the solution into 3 buckets: collective stakeholder effort, educational program changes, and employer changes. The first bucket of solution is on collective stakeholder effort. The solution within this bucket is to strengthen regional consortia made up of educational institutions, employers, and the community. A positive for this solution is that the regional consortia can coordinate placement more efficiently as it allows for open communications between the healthcare facilities and the institutions. A downside is that these consortia aren't formalized, so there is no guide or template on what an effective consortium looks like and how to build on existing ones. The next bucket of solutions is on educational program changes. The first solution is to increase the use of various simulation modalities like virtual reality, augmented reality, high fidelity simulation, or a combination of these. Supporters argue that students can receive timely and standardized training necessary, since faculty can control the choice of simulations, the integrations within the curriculum, and their desired learning outcomes. Simulations can be set up at appropriate times and locations and repeated as often as necessary. However, there are concerns about space and location constraints, along with simulations not teaching students interdisciplinary team skills, nor do they teach patient communication and patient safety. Simulations may also not be as rigorous as training based on face-to-face interaction. But what do simulations look like in practice? In order to help you all gain a better understanding of what a virtual reality simulation could look like, here's a video of a student assessing and treating a patient with asthma. You won't be able to hear the sound, but I'll quickly walk you through what happens. So at the start, the student would interview the patient and take an initial set of vital signs. Then they would assess the patient using their stethoscope to listen to the patient's breathing, as seen here. Going to fast forward a little bit, past the hearing of the breathing. So after they have been able to hear the patient's breathing, they are able to make a diagnosis. They can then treat the patient accordingly, which is done here through medication and a nebulizer. Again, this video just shows one type of simulation, specifically virtual reality simulation. And there are other types, and I can share those video links if anyone is interested. In addition to simulation, there is the use of telehealth as another way for students to achieve minimum competencies. Telehealth can be a safer option for students, hospital staff, and patients by reducing potential infectious exposures. However, telehealth is still pretty new, so the reimbursement environment remains uncertain. The last solution under this bucket is expanding the use of credit for prior learning, or CPL, and competency-based education, or CBE. CPL guides institutions in evaluating and awarding eligible students with credit for previous college-level learning that's gained outside of a college classroom. And CBE measures learning and grants credit for students who acquire and demonstrate their knowledge and skills by engaging in learning exercises that align with clearly defined programmatic outcomes. One of the positives of increasing the use of CPL and CBE is that it would allow students to move more quickly through their programs. They would also allow for international credentials to count as credit for certification or degrees and provide opportunities for immigrants and refugees to contribute to the field. However, the downside is that CPL can be difficult to implement in healthcare training programs, and accrediting bodies appear slow to recognize CBE allied healthcare programs. However, there are bright spots. The California community colleges began reforms on CPL and are in the process of establishing local CPL policies, and they're also ramping up their CBE reforms. The last bucket of solutions is employer changes. The first solution is to incentivize large clinical training sites. These incentives could look like a tax benefit, state assumption of liability insurance, or stipend to sites that place allied health students for internships. There is a positive fiscal impact that results in offsetting training costs, which is a positive for institutions providing clinical internships. However, it's actually against the law for community college programs to pay any type of incentives to clinical providers, but that's not the case for for-profit providers. The next solution is using untapped alternative physical facilities as clinical sites, including the mass vaccination sites that are happening throughout the state. Also, school-based health centers, pop-up clinics, prisons, and food delivery services for low-income and disabled residents, like Meals on Wheels. The alternatives to hospitals and clinics can help meet the training requirements of students who have limited access to their clinical training sites because of location, transportation options, or work schedules. However, students who train in these alternative clinical sites may not be as prepared to work in a hospital setting, and the training may not be as rigorous. The last solution in this bucket is on federally qualified health centers, or FQHCs. Their focus is on underserved communities and high quality care, which makes them great for clinical placements, as it would enhance student training opportunities and give underrepresented and rural students opportunities to do their clinical placements within their local communities. However, FQHCs tend to have a smaller infrastructure, including fewer staff and fewer resources. So after going through all of these different types of solutions and their pros and cons, what is the best way to move forward? What solution do we, California Competes, recommend? Well, first we evaluated each solution by a criteria, as shown in this table, which includes its political and technical feasibility, its impact on equity for allied healthcare workers and across regions of the state, its effect on current and prospective allied healthcare workers, and its anticipated degree of effectiveness in reducing the clinical hours bottleneck. We then rated the solutions based on that criteria, as seen here. So as you can see, the solutions have different impacts and levels of feasibility. There are strengths and weaknesses to each solution, and so it really depends on your specific region and community's needs. Therefore, our overall recommendation is that reducing bottlenecks requires a multi-pronged regional approach. So, for example, if your region or community needs a solution that would provide access for career mobility with appropriate pay for underserved populations, and that would lead to effective recruitment, training, and retention of the allied health student in a specific allied health field, then your community should look into increasing the use of simulations, as they're both high here, and exploring untapped alternative physical facilities. This was just a high-level overview of the study. For more information, please check out the full report, which can be found on our website. We will also provide a link in the chat box. If you have any questions, please submit them via the Zoom Q&A function. I want to conclude the presentation of the research by thanking the many who made this study possible. Our partners Civic Health, particularly Vaughn Tonquillivan, who you'll hear in a minute, and Dr. Grant Gould. And thank you experts and stakeholders who graciously gave their time and expertise by participating in interviews and follow-up interviews. And to the dozens of external reviewers who provided feedback. You're listed by name in our report, Meeting California's Demand for Allied Health Workers. Of course, all of our errors are our own. Lastly, thank you to Dr. Cynthia Schrager, the California Competes team, and the Leadership Council. I will now turn it over to Susan to kick off our panel discussion.
Great, thank you, Gail. I'm excited to kick off our discussion with our expert panelists. And first, let me introduce them. They're fantastic, and I'm going to spend a little bit of time on their bios because I know we're drawing from a spectrum of policy and educational leaders. Looking at the slide, just starting from the top left, Vaughn Tonquillivan, I'm excited to have join us. Vaughn Tonquillivan is the CEO of Civic Health, a new nonprofit whose mission is to improve the health and wealth of communities by growing the largest network of credentialed allied healthcare workers. Civic Health was founded by Kaiser Permanente and SEIU United Healthcare Workers West. Ms. Tonquillivan is a nationally recognized thought leader in workforce development with a proven record for implementing large organizational change while fostering a culture of experimentation, innovation, and collaboration. Prior to joining Civic Health, Ms. Tonquillivan served as the Executive Vice Chancellor of the California Community Colleges. She grew public investments from $100 million to more than $1 billion during her tenure by establishing workforce as a state policy priority. And it was at this time that Ms. Tonquillivan and I got to know each other based on our shared focus on improving higher education's responsiveness to workforce and economic needs. Her distinguished career spans the private, public, and nonprofit sectors. A few of her honors and recognitions include being a White House Champion of Change, receiving the California Steward Leader Award, and serving as a Stanford Media X Distinguished Visiting Fellow. Thank you for joining us today. Next, I'm happy to introduce Assemblymember Evan Lowe. Assemblymember Lowe represents the 28th District, California's 28th District, which includes Campbell, Cupertino, Los Gatos, Montserrado, Saratoga, and the areas of West San Jose, Willow Glen, Cambrian, and the Almaden Valley in San Jose. Assemblymember Lowe chairs the Business and Professions Committee, the LGBTQ Caucus, and is vice chair of the Asian and Pacific Islander Legislative Caucus. In 2015, Assemblymember Lowe launched the California Legislative Technology and Innovation Caucus, which is a bipartisan group of Assembly members and senators with the goal to ensure California remains the global leader in technology and innovation. Assemblymember Lowe is the first Asian American to serve on the Campbell City Council in 2006, and then made history once again as the youngest openly LGBTQ+ mayor in the country at age 26 in 2010. Next, I'm also happy to introduce Dr. Stacy Okender. Dr. Okender is the Vice President of the Commission on Accreditation of Allied Health Programs, CAHEP, and she's also the past president of the National Network of Health Programs in two-year colleges. Dr. Okender is also the Dean of Health Careers and College Health Advisory Officer at Metropolitan Community College and the former Associate Dean of the Graduate School and University College at Nebraska Wesleyan University. Dr. Okender is committed to growing leaders from within organizations and helping to develop people to their fullest potential through the identification of a vision, set of core values, and an implementation plan. Under Dr. Okender's leadership, her division at Metropolitan Community College has tripled in size, whose enrollment has tripled in size with the addition of 4 new associate's degrees and several certificate programs, while maintaining a student population that's 43% ESL or minority and represents students from 21 different countries. And last but not least, I'm thrilled to introduce Dr. Carol Mountain. Dr. Mountain has been involved in nursing education for over 30 years. She's taught in a variety of programs, including LVN, ADN, RN to BSN, MSN, and DNP. Currently, Dr. Mountain is the Director of Nursing for Sacramento City College and the President of the Board of Vocational Nursing and Psychiatric Technicians. She obtained her ADN and BS in Communications from Pacific Union College, MSN from Sonoma State University, and her DPN from California State University, Fresno. Although Dr. Mountain thoroughly enjoyed her time working as a registered nurse, her passion is nursing education, and she believes it's a privilege to prepare the next generation of nurses. So I am happy to have this excellent panel that provides a broad perspectives around the critical and key stakeholders in this complex multi-stakeholder environment that surrounds training allied health workers. I now invite panelists to turn on their videos, and Gail will take down, thank you, the PowerPoint slides so that we can see our panelists. Thank you so much for joining us this morning on this critical issue. And I have to say, we started this work before the pandemic, and it just, became even more important and exacerbated and highlighted how important it is for us to address this critical shortage. So I have a few questions that I would like to ask you, and then I see we have already a number of questions in the Q&A. So let's get started. So as shared by Gail in the research presentation, California Competes identified multiple potential solutions to addressing the lack of access to and availability of clinical hours that contributes to the allied health worker shortage. We identified strengthening regional consortia composed of educational institutions, employers, and community-based organizations, along with increasing the use of simulations as 2 of the most promising solutions. I would love to hear from each panelist about what are ways that we can advance these solutions and accelerate the uptake of these reforms, and what challenges do you anticipate these reforms facing? I will turn to Ms. Tan Quinlivan first to get your thoughts.
Well, thank you. I just wanted to start out by thanking you and California Competes for taking on this study, bringing visibility to this issue, which has surfaced in many reports across the state of California. And particularly great about the report was that it began to inventory sort of the collective thoughts around how to tackle these issues, like what are the different solutions that could be approached. I think what's important to note is, in the United States, we need to hire 2.3 million new healthcare workers for the front line by 2025, and California proportion, as you mentioned, is roughly 500,000 of that. And when you get to those numbers of those proportions, you realize that no one organization can actually solve the problem, right? It's going to be collective effort. And what's going to be so interesting about the problem set that you've laid out is that it's going to take collective stewardship. And I particularly liked the proposal to think about who are all the organizations within a region that can be mobilized to collectively steward this problem set. I know that within the community colleges alone and the workforce system alone, they have already begun working at a regional level and bringing assets together at a regional level employers, education, workforce system, et cetera. And here you've also inventoried a set of other actors like the federally qualified health clinics, which have suffered from high retention sort of high turnover issues and workforce issues. And so to be able to bring them into the solution set will be really important. And then I also want to cheer on the recommendation of simulation and giving some flexibility to take advantage of state-of-the-art technology and leverage that as a modality for training. So good work.
Great, thank you. And I'd love to open it up to our other panelists to respond about what are ways that we can accelerate these reforms, and what barriers do you anticipate in doing that work?
Is it all right if I respond?
Yes, please.
I just wanted to say that we're really fortunate in the Sacramento area. We have developed a consortium of all the nursing schools, whether it's community college or private schools, and all of the leaders from all the various facilities, so that we can coordinate our efforts and be collegial. I love that word that Van used, to forward the education of nursing. It's for nursing. Our consortium is for nursing. So for all levels of nursing students, and that we make sure that everybody has opportunities to get their students educated appropriately and in the best way that they can. And one of the things that I've seen over the past year, especially with the pandemic, is how flexible people have been and how willing they are to share sites, give up sites, and make sure that people are meeting their hours. So I think more collaboration between industry and education will move us forward in the way we want to go.
Yeah, and I can segue off of that. That's a great comment. Most community colleges are structured around service areas. So in my state of Nebraska, where I'm sitting, and I'm thinking that we're above 47 below today, so I'm all about that. What we found is if I don't have a surge tech program in my 4-county service area, I work with my other community college health deans to have their students come into this service area and get their clinical spots. It's no longer about these are my 4 counties and you shall not cross the line. It's about how do we serve our community and our patients best. Those are simple conversations. That doesn't take policy change. That takes people being honest and real and saying, I need help, I need access. When I listened to the original slides, and I love this work, a couple of things. So when we talked about consortia does not have regulations or guidance, they actually do. Under accreditation, there are sections and standards on consortia agreements. And I think if we start there versus going backwards, right? We hate to build and then somebody comes in and says, but here's the rule. We want to go back and start with the rule and move forward so that we can build those relationships and those consortia in a healthy way. The other thing I'll say is this: simulation is not just technology. And I love technology. Well, no, I really don't love technology because I'm horrible at it. But I love the idea of it, and I love those people who are so gifted. But let's think about other ways to do simulation. A mass casualty day, where I bring in people from the community and I moulage them to look like they've been, in an explosion or a crash or whatever. And I EMT students, my nursing students, my medical assisting students, all out there triaging that. If I used a checklist, I could be checking off all these competencies. And colleges will embrace that because it doesn't cost them anything. So in times of budget crunches, it's like, let's get real. What do we have easily accessible? That's people. And then it builds that interprofessional conversation. The last thing, and then I'll be quiet, is on credit for prior learning and competency-based. We make it way too difficult. We try to find all the reasons to say no before we say yes, which is ridiculous behavior. And it comes down to academics. Example, no one will ever convince me that a military medic is not as well trained as my EMT students because they've been trained in real life. So I'm going to accept that. They bring me their documentation. I match it to the objectives in a syllabus. I can check them off. I know they're there, but I also know they're going to be missing an OB/GYN rotation, or at least I hope they are, right? But I can have my faculty put together a competency-based test and some training to get them through that. So it just comes back to, let's stop making things so difficult and just use common sense to be able to say yes.
Great, thank you. Assemblymember Lowe, I wanted to also give you an opportunity to respond to this question about how can we accelerate the uptake of these reforms and what challenges do we anticipate facing?
Thank you very much. Well, first of all, thank you very much for having me, and to the panelists for your expertise. And for the participants on this, what is an assembly member? Like, seriously, what is an assembly member? And who is your assembly member if you're in the state of California? And if you don't have the answer to that question, that's a problem. And the reason why I mentioned that is we are that of the state legislature, and we represent each and every one of you in different regions throughout the state. And why that's relevant to you is that we are part of the solution in addressing the regulatory framework on legislative fixes and or helping to address some of your concerns. And so if we don't know who our elected representatives are to help ensure that they're informed and educated, that's a problem. So how do we advance this profession and to ensure that we're getting this type of support that we need, and also the accommodations COVID related? I've been seeing a number of questions and in also the chat, a flurry of them, to which here's what's an important characteristic to think about. Specific to nursing, the great starting point would be to obtain consensus among the Board of Registered Nursing, the nursing programs, and the nursing associations. And unfortunately, what happens is we, as the elected representatives, we're hearing competing interests. And so if we do not have a subject matter expertise in this area, we don't know who to believe. We'll have one meeting for 15 minutes and then it says, oh, well, that sounds rational, that sounds great. And then we get into another meeting, opposing view, and we also say, well, that actually makes sense too. And so what's important is to build consensus around this for the regulatory framework so we can address this big hurdle. And that's what I think the main challenge is. And so again, the big takeaway from my perspective is when coming to the regulatory and or the legislative side, when looking for the necessary fixes, try to help build some consensus to the best extent possible. Of course, there will be competing positions, but when coming to the legislature, if there can be as much consensus as possible, that's what I think can help benefit the direction in moving forward.
Great, thank you. And we are going to be sharing in the chat where you can log on and find who's your assembly member and your state senator. So thank you for that. Our civic role is so critical. I have a question specifically for each one of our panelists. Ms. Ton Quinlivan, a question for you. Futuro Health is taking on one of higher education's perennial challenges, increasing higher education's responsiveness to workforce needs. And this is something I know you've worked a long time on. Can you talk about why you decided to focus on allied health workers and why clinical bottlenecks are important to address?
Well, thank you very much, Sujin. Clearly, the magnitude of the issue warrants some additional attention. And again, in this space, when the numbers are so big, it's a question of like who has stewardship and responsibility for fixing the issue. And of course, it's particularly hard when it's dispersed like this. So we want to be contributing resources and be able to put visibility and light on some of these issues. Frankly, because we had been tracking this issue and working with California Competes, one of the things we were able to identify was that through the deployment of the mass vaccination sites, when we were approached on whether or not we could help, it occurred to us that these mass vaccination sites, just like Dr. Okender had mentioned, it's an opportunity for students to have direct patient care. So when we proposed that to Kaiser Permanente and the other health system, they said, yes, why don't you, Futuro Health, go out and reach out to allied health and nursing programs and see if they're interested in having faculty and their students use these mass vaccination sites in order to create clinical hours. And as a result, we have over 4,000 shifts being created over the next 3 months in just Moscone Center in San Francisco alone to create this. To the prior point about simulation, yes, it's technology and that allows for scalability and consistency. It also occurred to me that back when I was in the private sector, in working with energy, for example, there were mass emergency simulations, especially based around the major events like a big crash in San Francisco airport, for example. What would happen if that occurred? And the energy they would coordinate with all the emergency responders, the hospitals, not only the utilities, but also the airport, et cetera. And as as was laid out, there were people who played patients, and then there were operations team, like how do you respond? So, for example, every community has to go, with major airports, has to go through that type of emergency preparedness simulation. And can we then be proactive in weaving clinical hours into that activity rather than keeping these things as different worlds? So the more that we're actively thinking about the opportunity and how we systematically create the opportunity, I think collectively we have a better chance at closing the gap on some of these very, very large numbers.
Thank you. Assemblymember Lowe, last year you authored AB 2288 at the height of the pandemic, or I should say, knock on wood, right? We're not through. Hopefully that was the height of the pandemic, or getting there. This bill increases flexibility for nursing programs that face a reduction in clinical training hours due to COVID-19. The flexibilities include using a clinical setting without meeting specified requirements, using preceptorships without having to maintain specified written policies, using clinical simulations for up to 50% for medical, surgical, and geriatric courses, using clinical simulation for up to 75% of psychiatric mental health nursing, obstetrics, and pediatric courses, and waiving concurrency of theory and clinical by one academic term. I was hoping you could talk a little bit about what led you to address this issue. I know there are many issues in front of legislators, in this crisis. And then what feedback have you received since this bill has been enacted?
Yeah, so this was just a temporary to tackle the issue at hand. And how this came about is I was made aware that the committee that I chair is called Business Professions, and it oversees that of licensure and that of, for example, the Board of Registered Nursing. But number one, let's keep in mind that the Board of Registered Nursing was actually opposed to this legislation. And what I had heard from some of the groups and organizations in the district, including San Jose State, was, hey, we need this specific fix. Could you help address this temporarily? And so when coming up with the challenges of the times, we acknowledged the lack of consensus for the long term, but also understood that this is temporary in nature with this proposal. Of course, you can appreciate and imagine when you see something like this, there is a temporary proposal, then you're going to see a request to saying, well, could we make this more long-term now as a result of that? And I think that's the challenge that we are dealt with, to try to make that assessment. And it's difficult because I'll just readily admit, I'm not the subject matter expert. We are the regulatory and legislative side. And so we rely on your expertise. But when we go to industry and there's no consensus, it becomes that much more difficult to figure out. And so these conversations can be circular in nature, and the focus can be counterintuitive. So again, that's a call to action to say that we rely on your expertise to help us figure this part out and understand the scenarios that it might be situational and that there might be some unique differences, but how do we come together collectively on the outcomes to make sure that this is based on sound policy? And that's what we're attempting to do.
Great. And I see a lot of nodding from the other panelists. And I want to say, feel free to jump in if there's anything that, comes to mind as you're hearing other panelists' comments. So Dr. Mountain, as the director of nursing at Sacramento City College, your day-to-day work involves educating future healthcare workers. I was hoping that you could talk a little bit about what happens in the programs and with the students when you experience these bottlenecks.
Well, I really appreciated Assemblyman Lowe's comments. We're all there, you know, and we were so thankful when that bill came through, and it really made us all have a big sigh of relief, because we were looking for ways to continue to provide the clinical experiences that our students need in order to be well educated. And I am a big proponent of simulation. I love simulation. I've been doing it for over 15 years, but I don't think there's anything like putting your hands on a patient. And there's nothing like being in that clinical area and seeing what's happening and having that interaction with the patient to really provide for students what it feels like to be a nurse and what it means to be a nurse. So when students can't get the clinical experiences they need, it's a real deterrent for them. This is where we move theory into practice, and we see the student make this change. It's like it goes from their head into their heart, and they realize this is what I'm here to do. And they can take information from the simulation environment. Oh, I saw this patient in simulation, and now I can apply it when I'm in the clinical environment. But they need that time of being in the hospital, in the facilities, to have that patient interaction. And one of the things I am seeing that I wanted to bring up here, which has been very distressing, I've had several meetings with students these past couple of weeks, and the students are feeling very anxious about graduating and not being prepared to be the kind of nurse they want to be, because they were taken out of clinical in the middle of their first semester, and now they feel like they're playing catch up, and they feel like they've been playing catch up the whole time. And in some ways that warms my heart to know that they are this concerned about what they're doing. But I think that we're going to have to work collaboratively with clinical facilities, and we may need to consider some things like nurse residency programs, again, which we have done in the past, or other ways to make sure that these students transition into healthcare and they don't get in, spend a year, and then they go, I can't do this, I'm out. So I think it's a complex issue. And once again, it comes back to all of us talking to each other, working together, and looking for long-term solutions, not just the quick fix.
Well,
Yeah, if I can, go ahead, Assemblyman Member
oh,
Lowe.
my apologies. I was just going to just say that in terms of the conversation for a simulation, that's a key question, which is how do we ensure the standards that we use there's such a range of options. How do we standardize quality while also not stopping the student pipeline to continue to go through? So oftentimes those are competing interests, and that's what we're grappled with. So I'd welcome some insight on that.
Yeah, so
Go ahead.
So a couple of things. Speaking now as the dean, we did everything we could at our institution to not let our clinical sites push our students out. So the first answer, of course, was remove them. And I have to preface that by saying we don't use preceptors in our program. We use our full-time faculty or adjunct faculty who are always with our students in the clinical site. That's a commitment we made as an institution, and we continue with that commitment. But what we did was we helped them understand how our students were not a burden, they were help. So instead of moving their staff to their doors to take temperatures and check people in, keep them on the floor.
Oh dear. Dr. Okander, I think you froze on my end. Did she freeze? Okay. Hopefully she'll be back. Oh,
She's back. All right, can you hear me?
we can hear you now. You were saying
I don't know where I left off.
You were saying to keep them on the floor.
Right, to keep their employees, their staff who needed to be bedside and everywhere else. We basically just said, let us take over that screening. And we were able to stay there for quite a few months. And it was the same thing with our respiratory students, you know, and now honestly, we probably had 2 months we were not in clinical at the height of our peak here in Omaha, but the rest of the time we were able to find different functions. It's just sometimes convincing them you're a help, you're not a burden. And then to the question about simulation, I think the biggest issue is having faculty who are talented in the area of simulation, who can run those simulation labs and maintain quality, maintain rigor, maintain some semblance of consistency versus just adding that to a faculty member's job. Like that's a skill set. And I think we have to be aware of that.
I really have to support what you just said about simulation as a skill set. And there has to be some way, we do have these accrediting agencies now for simulation that can come in. And that is one thing that's been floated is, are we going to demand that colleges have some kind of accreditation to run their simulation lab? And I think in the future that probably will happen, but there's so many different ways to do simulation and many are effective. So I think finding that finite balance, I just have to mention telehealth too. It's so new, but we are currently, Sacramento City College is currently, we're dabbling in telehealth with our students to see if this is going to meet some of those needs to increase their interpersonal skills and to learn to talk to patients in this manner, because it's not going to go away. This is one thing that came out of COVID that we're going to continue to see is the use of telehealth. I am convinced of that. So I think all of these methodologies, bringing them together and helping people recognize that everything plays a role, but not the full role. And so how do you meter them out? And you know what? Every program is going to look different. And I think some flexibility for programs is really important.
On Twitter, I follow a teacher's site, and I just want to share this quote with you. And it was related to COVID. And it said, "Nothing should go back to normal. Normal wasn't working. If we go back to the way things were, we will have lost the lesson. May we rise up and do better." And I think that if we lose the lessons or the blessings of things that have come out of COVID, it's a shame. It really is a shame. And I've seen growth in our faculty who were like, "I'll never put anything online. I will never do a synchronous session." And they're like, "Okay, I want to keep it that way because now I can spend more time in the lab." And so there's many blessings. I just think we have to understand that normal wasn't the best, maybe, and that's okay.
Thank you for that. I also want to flag that when I asked this question, I noted that Dr. Mountain's role as a nursing educator, but I also wanted to flag in her very long bio, it may have gotten lost, but Dr. Mountain's also the president of the Board of Vocational Nursing and Psychiatric Technicians. So I just love that our panel has this breadth of experience from different stakeholders because training of allied health workers is very complicated. And my last question for Dr. Okander, and it builds off of Assemblymember Lowe's comment, the Commission on Accreditation of Allied Health Programs' missions to assure quality health professions education to serve the public interest. Given your focus on the quality of allied health programs, how do you ensure programs maintain a high level of quality while also encouraging them to be innovative and addressing shortages and bottlenecks? So how do you balance that, sometimes that tension, right? And lots of times the opportunity, as you just flagged in that quote.
Yeah, I think, so a history, one of my first college jobs was I was the program director over a KHEP accredited program. And I hated them. I thought, are you a rule maker? And I have to follow that and figure it out. And then I realized like that consistency was going to be my saving grace and going to ensure that I could get qualified faculty, equipment. Students were all receiving the same benefits of an educational program. So, fast forward all these years later and from the dean seat and now, being a commissioner and on to the vice president's role, those who see accrediting or regulatory bodies as the evil, they're not. They're here to help. And I say that because, as I mentioned, we accredit 2,100 programs in 32 different professions based on one set of standards. Now, from that, we have our COAs who then are in each profession, who then have specifics that pertain to each one. So if we want to talk simulation and we want to talk, emergency medicine, they're going to want trachs done on, a simulated model and then so many leads, team leads they're called. Those are real. They are the SMEs. They know what they need to have, but it all comes back to one set of standards. So we also report to CHIA, the Commission on Higher Education Accreditation. And innovation has been a big thing. As we've gone through our self-study and our site visit, we talk about, do we need to look at what we view innovation as being differently? We're exploring distance education, something that we really haven't done. I've been co-chairing that committee, and we've realized that best practices probably weren't always best. They were common, but they weren't always best. So let's look at that. And so in that consistency, I think it goes back to, there are a set of standards. This is to protect the public. We have a public member on our board. We ask that all of our COAs have public members, and all of the programs, like at my institution, every program has public members on their advisory committees. And that's to make sure that we really do have the public's best interest at heart. But the consistency, the innovation, you can have rules and still be creative and innovative within the parameter of those rules. And I want people to, we want people to, KHEP encourages that innovation because we all learn more from it.
Great, thank you. I want to turn to, we have a lot of questions coming in from attendees, and we will do our best to get to as many as we can. And I'm jumping in, I think some of the questions have been somewhat answered, so I'm jumping into the questions that are have been less answered. So a question coming in, many community colleges are only willing to pay instructors at 75% for a clinical course. I see nods already. Basically requiring 1.5 hours of work to get paid for 1 hour of teaching. This makes it very challenging to retain faculty. Has this been seen as an issue?
Oh, I could so address this. It's not just that, it's the whole idea that all nursing instructors, and I can only speak for California, community college nursing instructors work for a substantially lower wage than what they would make working in a healthcare facility. And we've actually had the experience where we hired someone to be a full-time faculty, and before we could even get the paper signed, another large hospital in town offered them 3 times the salary we were offering, and we just simply can't compete with that. And so the idea that you have people nurses that have masters and doctorates, and we're trying to bring them in and their pay isn't even half of what they would make in a facility, it's a big problem. There's a huge nursing instructor shortage across California. My program has 3 openings. I know that every program in Sacramento has openings, and we talk about this all the time. How do we make ourselves attractive to nurses when we're asking them to take 1/3 of what they used to get? And it used to be that it was pretty close when I came in 30 years ago. You took a little bit of a pay cut, but it was nothing significant because you were getting a little bit more flexibility with your time off. And now the demands of nursing education and what we expect of a nursing instructor outstrip what it was 30 years ago, and the amount of time and commitment, and yet we're only offering to pay 1/3 of the wage. And I'm not sure what the solution is. There've been some innovative things that have happened. I know one community college got the hospitals to stipend and give them a little bit more, but I'm not sure what the answer is. But there has to be value there for that person to want to sustain a teaching career.
Yeah, and it's not just healthcare. We see it in the trades. We see it when it comes to education. It's not a high-paid field. And we can fight that battle. That whole 75% thing, you saw my head kind of spin around and flip up and down. It's a constant battle. And part of the conversation that we have is getting folks to understand it's not a one-off. Like, these faculty are in these clinical facilities under their license, with students working under their license, which is their livelihood, and they are there to intervene on a moment's notice. This isn't a faculty member who's sitting at home and sending their students out and having somebody else handle them. And there's a misconception by senior leadership that that is what that clinical is, that it's kind of a lab tech thing where you really don't have a one-on-one interaction. That's our job. Our job is to make sure we continue to get in front of the people who make the decisions about that 1-to-1 ratio. And I fight it in our own state to tell them that this is the reality of what that looks like. And it's not what you've assumed it looks like. And the instructor shortage in nursing is real. And I get that. And I've been very blessed we don't have it here. But for us, that's not what's causing a bottleneck. And I have to say, we don't necessarily have a bottleneck here because we regulate admissions. We have all of our programs are selective admissions. So we know how many clinical spots we have. We know how many students we can take in. Now, the issue becomes maybe people don't want an evening clinical, or a faculty member says, I only want to work days, but that's not what we hired you for. So for us, because the other issue is we're not attached to a teaching hospital. So unlike, some of our friends in the city, we're out bartering and bidding on clinical spots. And so sometimes it is a 3 to 11, sometimes it is a weekend, all of those things, but we reduce that bottleneck in controlling our admissions, which doesn't help the workforce, but then that gives me bartering power to go back and say, if you want me to admit more, then give me some clinical spots. I will be honest and say hospital seeking magnet recognition has absolutely hurt the community colleges because they're limiting how many associate degree students can come in because they're only hiring bachelor students, although the terminal boards are at the associate degree level. If you want a workforce, understand the pipeline.
Well,
And that's how we address it.
We've kind of circumvented that issue by offering concurrent enrollment to all of our students in our program at Sacramento City College. I know they're doing it. We work collaboratively with the other community colleges in our area, and every student has the opportunity to be in concurrent enrollment should they choose that. And now the magnet facilities here in Sacramento are saying, if your students are in concurrent enrollment, we will hire them, which is that's a big boon. That's a step in the right direction.
And that's what we've done here. And so I love it. I love going to the med center and seeing our students. And, we have about 84% of our students who all go on for their bachelor's degree, and they use their employer's money to pay for it. That's a wise consumer, and that's what we tell them. We're $69 a credit hour. And so we're like, that's not much to get your associate's degree. Get hired and now use tuition remission to pay for that next degree. And that's not just here. That's what I'm seeing from, our KHEP affiliates and COAs as well, that those programs are doing the same thing. It's really coming down to economics.
Thank you. I know we just have a few more minutes left, so I think we have time for one question, and we'll wrap up around 10:57 or 10:58. Another question that came in was, as many clinical experiences for students are prescribed by accreditors and state regulated, how do you propose to overcome those challenges to allow for increased simulation experience and experiences outside the acute care setting?
So the Board of Vocational Nursing just 2 weeks ago, or maybe it was last week, put on an entire program for the board members and opened it up to the public. And we went through and talked about all these different kinds of simulation so that the board members themselves would be educated, because many of them are public members and they haven't had the simulation experience. They don't know what we do. They don't quite understand what that's going to look like. So we opened it up to them. We brought in NCSBN, which is a National Council of State Boards of Nursing. We opened it up to the public, and it was simply a day of education about what are these different modalities that are available for nursing education and how do they fit in the larger umbrella of what we're trying to get done. And people loved it. It was an awesome day. So that's one way to do it, is educate people.
And maybe you could just give some final thoughts as well to answer that too, is a few things. One is programs are worried that they'll need more time, potentially through the 2021-2022 academic sessions, but the state of emergency could end sooner. Secondly, some want the changes to be permanent. So for instance, 50% simulation and the waiver of concurrency requirement, suggesting that thought of which could precede clinical placements by one term. And then finally, just having flexibility, I think, is a significant relief. The big challenge of the rigid nature, oftentimes, of the approvals from the BRN is that programs don't always know about the clinical placements and when they will work for the next term and how they'll be implemented for the next term. So I think more certainty and clarity, it will be helpful.
I would just add that.
Sorry, my comment is that it's, as you've said, Dr. O'Connor, it's a moment in time where we should not go back to the prior playbook because it wasn't working well enough. And so, we have the nascent structure of regions working together. How do we mobilize that so that we're building the collective consciousness, but also the sort of the legislative agreement so that Assemblymember Lowe and Dr. Mountain can begin taking those agenda to get relief, and to create new ways of doing things, or more freedom to do some of the innovative practices that have been shared here, but in many other locations.
Thank you.
And I just want to go ahead. No, go ahead.
I will do a very fast wrap up. We had a question from a student that I thought we could maybe get to really fast. So the student says, I'm currently a community health worker student at Sacramento City College. Has the pandemic exposed a greater need for community health workers? And do you think the need will increase or be utilized more moving forward? Okay, I see nods. So there we go.
Resounding yes, resounding yes.
Yeah.
We're hearing from all of our clinical facilities, especially the community health centers, that yes, they want to hire community health workers, and this is definitely a field that's growing.
We're definitely
here in the Midwest.
Go ahead.
Go ahead.
Our board has approved a 2021 roadmap with community health workers, but with the behavioral health skill sets. And that's what we're going to invest in, to underwrite people tuition free to get into those jobs.
Yeah, here we, that's really been kind of a coastal position. And so for about 3 or 4 years, a group of us in public health have been fighting for the community health worker. And we are blessed that the Med Center, UNMC, actually got a Beacon grant. And so our students are attending a 5-course series that we put together for community health workers, and all of those sorts of things. And again, like I said, I like to stay positive. So one of the other blessings of COVID is they needed them fast, and they were paying them well. And so the years of conversations of saying these roles have a huge benefit to your organizations. And we were met with, now we're met with, please let us have them. And so that was wonderful. I just want to close and say, from all my years in accreditation, and I can speak from a KHEP standpoint, we're not the enemy. We want programs to be successful. We do not want a bottleneck. We want to be innovative. We're learning to be innovative. We're doing virtual site visits. I'm sure we never thought we would be doing that a year ago, maybe. But that comes in a conversation. And so it's not, I'm just not going to tell, or I just don't know, or they're always going to tell me no. We want people reaching out to us. We want people saying, have you considered? What do you think? And then to move forward that way as we move forward together.
And I'm so glad that you closed with this question from a student. Shout out to the students. It was because of your engagement and advocacy on Facebook groups, on Twitter, on social media, that we understood and we heard your compelling story about the situation that you were in. And it's because of that we've pushed forward with the legislation, again, in competing with the position of the Board of Registered Nursing, because we felt your pain and had great empathy for you. So it's because of your engagement that we were able to be successful. So let's not let up, and we look forward to making sure that we are doing the policy changes to support you moving forward.
Well, thank you so much. I know it's a little bit past 11, and I am so sorry. There were so many great questions that we weren't able to get to. But I encourage our panelists to take a look, and perhaps it's informative for your own work. So thank you so much to the panelists for joining us. And thank you again to Gail Yen, California Competes Senior Policy and Research Analyst, for leading this work, and the rest of the California Competes team who contributed to this work, David Radwin, Elaf Isaf, and Kim Burnett. The slides and the recording will be sent out soon, along with a short survey to learn more about your thoughts on this webinar and how useful you found it. And please take time to visit our website, subscribe to our newsletter, and download the report. Thank you so much, everyone.
Sujin, I'm fine if you want to share my email with attendees as well, if there's any way that I could ever be helpful to folks.
Great. We'll put that in the chat right now.
Yeah, I did, but just in case anyone missed it, I'm more than happy. I don't know a lot, but what I do know, I'm sure happy to share.
Entirely too modest. Thank you for that.